Hi, everybody. Dr. Nick here, and we are back to talk about patellar tendinopathy. And the name tells you exactly what it is. Patellar, so of course, below the patella, infrapatellar ligament or tendon, whatever you want to call it, doesn't really matter. And you have an irritation or pathology of it. So quadriceps tendon, basically looking at what's called jumper's knee. I would not call it jumper's knee. Call it the anatomical condition that it actually is. Some people confuse jumper's knee and runner's knee and a whole bunch of other sport-related knee, soccer knee, whatever else it is, with multiple different pathologies, and it leads to confusion. So patellar tendinosis, tendinitis, runner's knee, jumper's knee, again, just call it for the anatomical pathology that it is. So forces through one leg from jumping on one foot can land up to 12 times body weight. And in fact, I was reading another study talking about being up to 15 times body weight in triple jumpers. Absolutely crazy. So that's a ton of force. So if you weigh 165 pounds, that's over 2,000 pounds of force transmitted through that knee. That is crazy. Eccentric and concentric loading. This will eventually result in micro tears of the ligament itself. It leads to pain and loss of tensile strength. The microscopic tendon thickening that we can see, macroscopic tendon thickening and cartilage degeneration. And in severe cases, especially with deconditioning, because the pain makes the person not want to move very much, even patellar tendon ruptures. And they are not uncommon. I shouldn't say they're common, but there are many documented cases of patellar tendon ruptures. Nasty, nasty injury if it happens. So the best thing to do is safe loading over time. Incidence, estimated 20% of jumping athletes. Peak incidence, peak athletic years, this 18 to 35, roughly equal male to female. Yes, longer patellar inferior pole may be associated with chronic patellar pain. Again, the research is kind of mixed on this. Risk factors, number one that you have to get is going to be overtraining, okay? Jumping sports, volleyball, basketball are your main ones right there. Poor jumping and landing technique. And it might sound crazy, but we have to teach people how to land correctly, okay? How to absorb force through multiple tissues rather than just taking it right through the quads or right through the tendon. Inflexibility or weakness of the hamstrings can be there as well. Rapid increase in activity. So if you're not following the 10% rule, do not increase load or intensity by more than 10% per week. And you might even do it a little bit slower than that to make sure there's adaptation. If you want to see a great video we have up on YouTube, type in Vizniak tendons. And if you look at that one, I show my forearm as the academic forearm. I show a powerlifter's forearm, and then I show the tendons of a rock climber. And you can just see the substantial difference in thickness of training over time. Court surfaces that are hard or sloped, increase body weight or height may also increase the load. So the increased body weight is simple. It's just mechanical load. But same thing with the height. As you get longer bones, you have longer levers that can pull a little bit harder and may increase the load as well. And if we look at our basketball and volleyball players, if you are going to be an elite level player at that, you tend to be of the taller persuasion. Overpronation, worn out footwear may play a role. Nothing distinctive there in the literature, but something to look at definitely. So history, anterior knee pain, aching or itching quality below the patella is what you're looking for. Rarely above, where you could have some irritation above it as well in some of those tendons. Pain is worse with excessive activity. So at the end of their sport, at the end of their day, relieved by straightening the leg, which we know takes pressure off, especially if the quads are relaxed. And history of risk factors, looking for those jumping activities. So stages of progression. Stage 1, pain only after activity. They can still do everything they want. Stage 2, during and post activity, although performance is okay in their sport. And then stage 3, prolonged pain after the activity with difficulty performing basic daily activities. And grade 4 requires surgical repair. There may be patellar displacement superiorly as well, more associated with a full rupture. In physical exam inspection, potentially altered gait. Rarely you might see swelling. The affected tendon may appear thicker as well. Kind of something we see with Achilles tendonitis as well, as you see the video on that. Local point tenderness over the tendon is your key finding, and this is easy to palpate. Find the patella, go inferior to that relatively soft thing compared to the bone of the patella. If they have tenderness, you are probably looking at irritation of that tissue. There could be some hamstring or especially quadricep tightness, possible compensatory dysfunctions as well in other areas, which is why we're going to focus some joint mobilizations into those and stretching and massage into that to make sure they're moving correctly. Motion, active range of motion with squat will probably make it worse or feel weak, okay, especially as they get deeper down and really tug on that tendon where you have them jumping in front of you. Mild pain with passive range of motion, end range, possibly, not usually. with the stretch of the tendon, and possible pain with resisted extension if you really contract hard. Ligament laxity should be within normal limits. Same with neurovascular screen. So differential diagnosis list, you're looking at Osgood Schlatter's, because this could be in even a 15-year-old here, right? 12-year-old potentially. Chondromalacia patella should be a little bit different picture that you're looking at there, more retropatellar pain. Osteochondritis dissecans and meniscal tears, look for that locking, buckling, catching of the knee, giving way. Quadriceps injury, they should usually have a mechanism that follows that. Retropatellar subluxation or dislocation, you should be able to, they should probably say they felt the patella slide out of position, or if it is out of position when you're doing your evaluation, usually up in laterals where you'll see that. All right, special tests. Palpable point tenderness literally is the best finding in the literature. Single leg stance or hop or functional test is not a bad idea. You might also jumper's knee is strongly suggested when chondromalacia patellar's tests are negative. Again, for the general practitioner, they might not be aware enough of where the retropatellar pain is versus the infrapatellar pain is, because it is a couple of centimeters in different location. But if they are giving you no positive patellar grind test, the Waldstein's test is negative, they don't point or try and lift up their patella to make it feel better, then the patellar tendonitis becomes higher on my list. Diagnostic imaging, not needed for this condition, might be useful to rule out other conditions. Ultrasound might be pretty good, so you can actually see the outline of the tendon and maybe look at some of the vascularity or thickness comparing left to right side. X-ray and MRI really only there to rule out other conditions. MRI is not really a cost-effective choice for this condition, so consider the ultrasound if you want to. If there was a mechanism of trauma where you're worried about a fracture, maybe go ahead and think about other ideas there with an X-ray. Okay, so management, price or meth as tolerated. Really, I leave this on a person-by-person basis. Some people prefer the heat. Some people prefer the ice. We know that healing is better with heat, or just leaving it alone and letting the body progress through its natural process and just supporting motion. But our key thing here is education, empowerment, exercise, and then our manual therapies, right? Avoid activities that increase patellofemoral pressure, at least in the short term. And yeah, you're going to gradually work back up to developing better strength. You're going to look at massage therapy is a great choice. Anything that's going to be myofascial releases, Swedish techniques, instrument assisted techniques are all going to be winners over top of those quads, and maybe even over top of the patellar tendon itself. Osseous mobs, focusing on areas of compensation, absolutely. Extra, what are we looking at? Electrotherapies, shockwave therapy may also show some benefit as well. Okay. You can also look at acupuncture, meds in the short term. If it's been a chronic case where you haven't seen benefit with a lot of your conservative management, prolotherapy may be an option as well. You see pretty good success rates with that potentially. I often wonder about some of that research, though I haven't seen excellent studies. I've seen okay studies on prolotherapy. Yeah, indicated if other conservative treatments have failed. Wouldn't be my first go-to. Look for some other things. Surgery rarely required unless you have a full rupture, and the surgical repairs show excellent outcomes as well. All right, so what do we have? Follow-up. You're going to go knee immobilization is contraindicated. A lot of people do this. Do not immobilize. Keep moving the structure around gently. Eccentric quadricep strengthening might be of benefit. Yeah, this was a study from Johnson et al. It was a great study, actually, pretty good one that showed the eccentric loading, but we know that as a general rule. Eccentric loading is not a bad way to go for a lot of our conditions. Patient education, proper footwear, and orthotic use if there is some kind of overpronation or other issue taking place. Patellar tracking problem. Consider changing the activity type or lifestyle, moving towards balance exercises, changing the way the knee gets loaded. So loading it from different angles, switching up your activities a little bit. So it's not always the same loading strategy. And again, reevaluating the jumping and landing ability that this person has as well. Prognosis, 3 weeks, you should see significant improvement as the tissue starts to heal itself. Stage 3 may take longer and require more significant lifestyle modifications, and it will often coexist with other knee pathologies such as instability or ligament laxity, chondromalacia patella, and expect healing to be longer if they have other coexisting morbidities with it. So what am I going to do to strengthen up this patellar tendon? Squats are going to be a win. Lunges are going to be a win. Even simple stretching is going to be a win to start with as a simple passive range of motion. Okay. These Nordics, if you have a soft surface to work on, might not be a bad idea as well. But all of it is designed and eccentric loading to increase the load tolerance of the tendon without causing inflammation. So graded exercise exposure. Number one, educate your patients, empower them. Baby steps and graded exposure to activity and exercise. And then our manual therapies come out and help facilitate the optimal healing as well. Of course, I didn't really say too much on it right here. If there was a nutritional deficiency, you want to make sure that they have the right nutrients and building blocks to help heal this tissue as well. Fantastic condition. Thank you very much for your time, and we will see you in the next video.